Is a benign pituitary tumor, or it's a pituitary adenoma. It is the most common type of adenoma. So prolectinoma is basically a pituitary adenoma that produces prolactin, which will lead to hyperprolactinemia. So in yesterday's lecture, we discussed the sign and symptom or feature of hyperprolactinemia in females and in males. The features of hyperprolactinemia in females is galactorrhea, amenorrhea, and in males, the features include erectile dysfunction, decreased libido, and reduced fertility. So if someone present to you with these features, then you will suspect prolectinoma. You will order, the investigation that you will order is prolactin level. And so can someone of you tell me any other cause of hyperprolactinemia other than prolectinoma? Because we need to. So can someone of you tell me any other cause of prolactinemia related to hypothalamus?
Lactation.
What are the? Yes, lactation is a physiological condition in which there can be prolactinemia. So can anyone of you tell me any specific cause that is related to or hypothalamic causes of lactinemia?
Hypothyroidism.
That's right, excellent. Hypothyroidism uh, will lead to increased release of TRH hormone from hypothalamus, and it can lead to hyperprolactinemia. Or any hypothalamus will also lead to prolactinemia. Why hypothalamic failure leads to prolactinemia? Because the release of prolactin gland is inhibited by a neurotransmitter or hormone that is released by hypothalamus, and that is dopamine. Problem with hypothalamus or hypothalamic failure due to any reason, there will be decreased production of dopamine. It will lead to prolactinemia. So two causes you need to remember that are related to hypothalamus which can cause hyperprolactinemia. One is hypothyroidism, which will lead to increased secretion of TRH, and the second cause is hypothalamic failure. Hypothalamic failure will lead to decreased production of dopamine, and dopamine has an inhibitory effect on prolactin secretion. So if there is no dopamine, hyperprolactinemia will occur. Now, moving forward, causes that are related to dopamine that can cause hyperprolactinemia. What are those causes? The drugs which are dopamine receptor antagonists, such as antipsychotic drugs and metoclopramide, antiemetic, they can cause hyperprolactinemia as well. And some gynecological problems such as polycystic ovarian syndrome can also cause mild hyperprolactinemia. So if a person present to us with galactorrhea and amenorrhea or decreased libido or erectile dysfunction, after excluding other causes of prolactinemia, and if his prolactin level are, remember that normal prolactin level are 400 milliunit per liter. Normal prolactin level are 400 milliunit per liter. In the condition that we have discussed, the prolactin level is up to 1000, or in other words, in all these conditions, prolactin level are mildly increased. But in prolactinoma, they are massively increased. So the prolactin level are more than 4000 milliunit per liter, then it is most probably macroprolactinoma. And if the prolactin level are less than 2000 but still more than 1000, then it is microprolactinoma or a non-functioning macroadenoma that is compressing the pituitary stalk. So if a person with prolactinoma will have two type of features, one that are due to high prolactin levels, and the other that is due to pressure pituitary adenoma. Because pituitary adenoma will leads to an increase in the intracranial pressure, so the person will complain to you of headache. And also remember that pituitary gland lie in close proximity to optic chiasma. So a pituitary adenoma can compress optic chiasma, and whenever there is compression of the optic chiasma or any abnormality of the optic chiasma, what type of hemianopia will develop? Can anyone answer that? The type of hemianopia that a person will develop due to compression of optic chiasma.
Bitemporal hemianopia. Numbness.
Yes, bitemporal hemianopia because yes, that's right. Bitemporal hemianopia because temporal fibers are crossing to the opposite side at the optic chiasma. So a person with features of hyperprolactinemia plus headache and bitemporal hemianopia, you will suspect prolactinoma. His prolactin levels will be increased. If his prolactin levels are less than 2000 milliunit, then it is either a microprolactinoma or a non-functioning macroadenoma that is compressing the pituitary stalk. And if the serum prolactin level are more than 4000, then it will be macroprolactinoma. Macroprolactinoma may cause visual symptoms such as bitemporal hemianopia and headache as well. The diagnosis of prolactinoma is made on MRI, and the management, as the prolactin secretion is inhibited by dopamine, so dopamine agonist can be used in the treatment of prolactinomas. Example of dopamine agonists that can be used in the treatment of prolactinomas include cabergoline and bromocriptine. If it's microadenoma, what what is a microadenoma? If the size is less than 1 centimeter or 10 millimeter, then it is a microadenoma. So microadenoma is treated with medicines or drugs only. While macroadenoma, the treatment of macroadenoma is drugs plus transsphenoidal surgery. So the management of prolactinoma is simple because prolactin secretion is inhibited by dopamine. So dopamine agonist can be used such as cabergoline and bromocriptine. If it's microadenoma, then only drugs will be used. And if it's macroadenoma, then drugs plus surgery will be used. And if the disease is failing to respond to medical treatment, then surgery can also be done to relieve the symptoms. Remember that dopamine agonists such as cabergoline and bromocriptine can shrink the size of prolactinoma and result in the relief of the symptoms such as bitemporal hemianopia. Uh, Hypothalamus release two hormones which control the release of prolactin from the pituitary gland. One is a stimulatory hormone, which is thyroid releasing hormone or TRH, and the other one is inhibiting hormones, that is dopamine. The drugs, dopamine antagonists such as haloperidol and reserpidone. If someone taking antipsychotic drugs such as haloperidol or reserpidone and present to you the erectile dysfunction, then the cause is most likely hyperprolactinemia. So if in the Plab 1 exam, a person taking antipsychotics present to you with erectile dysfunction and they ask you about the cause of his symptom, then the cause of his symptom will be haloperidol or hyperprolactinemia.
Dr. Shah, if you scroll up a bit, it says dizziness is one of the signs.
Yes, dizziness can also occur, but
Why?
focus more on erectile dysfunction. Dizziness is
Okay.
not related to prolactin. Antipsychotic agents can cause dizziness in general because haloperidol is a not only a dopamine receptor antagonist, it also acts on many other receptors such as acetylcholine receptors and alpha receptors. The function that is related to the dopamine receptor is erectile dysfunction.
Okay.
So PCOS can also cause hyperprolactinemia, but remember that in PCOS, the hyperprolactinemia is mild. And the other feature which will help you differentiate PCOS from other causes of hyperprolactinemia is that in PCOS, LH and LH and FSH ratio is double, either double or more than double. Premature ovarian failure can also cause hyperprolactinemia. Again, it will be mild, and the other feature that will help you differentiate premature ovarian failure from other causes of hyperprolactinemia is that FSH level will be high on more than 25 in two consecutive occasions 4 weeks apart. In hyperprolactinemia, remember that high prolactin level causes a suppression of gonadotropin releasing hormone from hypothalamus, GnRH, gonadotropin releasing hormone from hypothalamus. So high prolactin decrease production of GnRH from hypothalamus. If there is decreased production of GnRH from hypothalamus, there will be decreased production of FSH and LH from pituitary gland. And if there is no FSH or decreased production of FSH and LH from pituitary gland, remember that the function of FSH and LH in female is that it stimulates the ovary to produce estrogen and progesterone. So in hyperprolactinemia, due to prolactinoma or pituitary adenoma, FSH, LH, and estrogen or estradiol, all three of them will be decreased. Hyperprolactinemia due to pituitary adenoma, LH, FSH, and estradiol or estrogen will be decreased due to a feedback inhibition of GnRH from hypothalamus. Is this point clear to everyone? I will take silence as yes. So the most common pituitary adenoma is prolactinoma. The second most common pituitary adenoma is a non-secreting or non-functioning pituitary tumor. And the third most common is growth hormone secreting adenoma. So if there is a growth hormone secreting adenoma, growth hormone secreting pituitary adenoma, what will happen? It will result in acromegaly. So if there is a pituitary adenoma which is secreting excessive growth hormone, it will result in acromegaly. The cause of acromegaly in 95% of the cases is pituitary adenoma, and in 5% of the cases, other tumors can also produce ectopic growth hormone or growth hormone. Example of other tumor is pancreatic tumor can sometimes produce an ectopic growth hormone. So in 5% of the cases or in minor cases, the cause of acromegaly is ectopic growth hormone production by some other tumors such as pancreatic tumor. What will happen if there is excess of the growth hormone? Hands is there will be excessive sweating and oily skin. There will be pituitary tumor such as headache, but and hypopituitarism as well. So we will be discussing the features of growth hormone excess: increase in shoe size, increase in ring size, widespread teeth, or increase in interdental space, horse-wise, carpal tunnel syndrome, prognathism, and macroglossia. So coarse facial appearance, prognathism, macroglossia, and increased interdental spaces. These findings will be present in the face. Increased shoe size, increased ring size. These will be these are the some hints that will be given in the exam. How we diagnose or what are the investigation that we need to do to diagnose acromegaly or growth hormone excess, you need to remember two tests, that is serum IgF levels, serum IGF-1 levels. What is serum IGF-1? Serum IGF-1 is insulin-like growth factor. Remember that growth hormone exerts its action through insulin-like growth factor 1. So the initial test, remember that the initial test or the screening test, and it is also a monitoring test to monitor the disease. Three things, three things that you need to remember about serum IGF-1, that it is the initial screening test, it is the initial test or it is screening test. And third one is that this is also a test to monitor the disease in acromegaly. So the first test that we will do if we are suspecting acromegaly or growth hormone excess, that is IGF-1, IGF-1 levels. And if IGF-1 levels are raised or high, then we will perform a oral glucose tolerance test with serial growth hormone measurements. So what is a oral glucose tolerance test with serial growth hormone measurements? Remember that in normal people, hyperglycemia suppress the growth hormone levels. So if we give 75 gram of glucose to a normal person and we measure his growth hormone levels before and after giving glucose, then his growth hormone level will be suppressed. But in a patient of excess growth hormone or pituitary adenoma, that is excreting excess growth hormone, there will be no suppression of growth hormone after giving him glucose. So initially IGF-1 levels will be done. If they are raised, then OGTT with serial growth hormone measurement will be done. And a positive OGTT serial growth hormone measurement, if it's failed to suppress the level of growth hormone or glucose or hyperglycemia, fail to suppress the level of growth hormone, then it will confirm our diagnosis of growth hormone excess or acromegaly. And to confirm the underlying of excess growth hormone, we will perform an MRI of pituitary gland to demonstrate a pituitary tumor. So in short, remember that excess but growth hormone levels, measuring the growth hormone level is not a diagnostic. It's not reliable because the level of growth hormone vary during the day. That's why we do not measure growth hormone for the diagnosis of acromegaly. Instead, we measure IGF-1 levels and we do OGTT with serial growth hormone measurement to confirm our diagnosis. And after confirming the diagnosis to see what is causing the excessive hormone production, we perform an MRI of pituitary gland to demonstrate a pituitary tumor.
Can you please repeat this oral glucose tolerance test with growth hormone?
Yes, oral glucose tolerance as in normal people, if we give glucose to a person, then his growth hormone will be suppressed. But in a person with excessive growth hormone or in a person with acromegaly, after giving glucose, his growth hormone level will not be suppressed. In normal people, lack of suppression of growth hormones. In normal people, the growth hormone is suppressed to levels less than 1 microgram per liter or 2 milliunit per liter. So in normal people, giving 25 gram glucose in a oral glucose tolerance test, the growth hormones should be suppressed to a levels of less than 1 microgram per liter or less than 2 milliunit per liter. But if it does not happen, then it is acromegaly, growth hormone excess of pituitary adenoma, which is producing growth hormone. Is it right?
Yeah, but what is the mechanism of action? I mean, like why it is linked with the glucose tolerance test?
Remember that growth hormone causes hyperglycemia, cortisol causes hyperglycemia, glucagon causes hyperglycemia. There is only one hormone in the body that causes hypoglycemia, and that is insulin. All other hormones causes hyperglycemia. Because growth hormone causes hyperglycemia, and hyperglycemia will lead to a decreased secretion of growth hormone through a negative feedback inhibition. So that's why oral glucose tolerance test is done for diagnosis of excess growth hormone.
Okay.
Any more questions?
Thank you.
You're welcome. So the treatment is surgery. What is the medical treatment, or what are the drugs which can be used in the treatment of acromegaly? One is somatostatin analogs. Somatostatin usually inhibit the release of growth hormones. Sometimes pigvisumant can also be used. Pigvisumant is a drug that is a growth hormone receptor antagonist. So the medical treatment of acromegaly is somatostatin analog and pigvisumant. And dopamine agonist can also be given if sign and symptoms of hyperprolactinemia is present, because in 6% or 10% of the patient of acromegaly, sometimes hyperprolactinemia is also present. So if it's present, then dopamine agonists such as cabergoline and bromocriptine can also be given. And the definitive treatment is transsphenoidal surgery. So pituitary tumor are treated with, or pituitary adenomas are treated with transsphenoidal surgery. Either it is a prolectinoma or it is a growth hormone secreting pituitary adenoma. The method of surgery is same, which is transsphenoidal surgery. So acromegaly and prolectinoma, these were abnormalities of pituitary gland or the hormones that are secreted by the anterior lobe of the pituitary gland. Their abnormalities. Now we are going to discuss another abnormality that is associated with the posterior lobe of the pituitary gland, a hormone which is known as, is it clear to everyone up to this point?
I had a question.
Yes,
For the prolactinemia, you
yes,
mentioned the treatments, the two drugs that you mentioned, the cabergoline and the bromocriptine.
bromocriptine.
Yeah.
Yes,
So, like, how long should that treatment go on for? Um, are you always supposed to operate after starting the treatment? Does it usually differ from patient to patient? How does it work?
if the tumor size is small or if it's a microadenoma, then it's understood that surgery will be difficult to perform. If the size of the tumor is less than 1 centimeter or less than 10 mm, 10 mm is a very small size. So microadenomas are best managed with bromocriptine and cabergoline. But if there is no response after treating with bromocriptine or cabergoline for 4 months and there is no response, then we go for transsphenoidal surgery. While in case of microadenoma, we can give the patient bromocriptine and cabergoline for 2 to 3 weeks and then perform the surgery.
Okay.
So now we'll discuss the normality of the hormone that is secreted by the posterior lobe of the pituitary gland, and that is ADH, antidiuretic hormone. Antidiuretic hormone is a water-loving hormone that is released by the synthesized in the hypothalamus, and it is stored in the posterior lobe of the pituitary gland and secreted by the pituitary gland.